Okay, so let's just talk a bit about fungal infections. So fungal infections can occur in a superficial way. They can live on your skin. Uh, you can have oral yeast infections. You can have vaginal yeast infections. And when they live on the skin, we call them dermatophyte infections. Dermatophyte is just another fancy word for fungal infection. So we'll talk about a number of different types. Fungal infections on the skin love moist, warm areas. So anywhere where there's two folds of skin together, and in warm weather, you are prone to getting a fungal infection. So whether it's under the breasts, in the groin, between your toes, very common places to get superficial fungal infections. Deep fungal infections are infections that are typically, well, not on the skin or in the mouth, but typically in the lung, in the brain, in deeper parts of the body, and they usually signify some kind of reduced immune system in the patient. Okay, so what kind of patient would be at risk for a fungal infection? Well, if we're talking about a superficial fungal infection of the skin, and when we talk about superficial fungal infections, we usually call them tinea. So tinea is just the name of the for a fungal infection. So if it's on your head, we call it tinea capitis. If it's on your body, we call it tinea corporis. On your feet is called tinea pedis, and in your groin is called tinea cruris. So just uh, to allow us to know which part of the body is affected. Okay, so the first one here, HIV infected patients. They're at risk for deep fungal infections, whether it's in their lungs, in their brain, uh, an assortment of places deep in the body, and they need oral antifungal medications to clear them. Unlike superficial fungal infections, such as on the skin, they typically just need creams to treat them. Patients on chemotherapy, they're immunosuppressed. They are definitely at risk for bacterial infections, viral infections, and fungal infections. Anybody with an indwelling catheter, again, bacterial infections are extremely common, and fungal infections can also occur, but often will give someone a bladder infection from a bacteria due to the indwelling catheter, or sometimes just from the insertion technique. Patients on broad spectrum antibiotics often can develop thrush in the mouth, which is very treatable with oral antifungal rinses. And women, of course, can develop yeast vaginitis, which again can be treated with uh, antifungal creams, or there's also a one-dose pill called diflucan that can be treated to clear a yeast vaginitis. Patients on steroids are immunosuppressed, so they have general immunosuppression. They are at risk for developing bacteria, viral, and fungal infections. And diabetics are also immunosuppressed. If you have a diabetic patient, consider them immunosuppressed. And they can also develop fungal infections from the immunosuppression and also poor circulation to areas of their body, such as their feet, that are prone to all kinds of infections. Okay, so how can we divide fungal infections so that it makes more sense? The best way to divide them is superficial versus systemic. So superficial, as we previously discussed, are typically skin, oral mucosa, vaginal yeast infections, Usually fungal infections that are accessible or treatable with topical creams and sometimes oral medications as well, briefly. For example, I mentioned that we use an antifungal called diflucan, and it's just one pill for a vaginal yeast infection. For thrush in the mouth, we often use liquid or solution antifungals that you can put into the mouth or into the child's mouth, since thrush is very common in children. And usually 5 to 7 days later, the thrush is resolved. Versus systemic systemic fungal infections, which are much deeper. They can be, as I mentioned, in the lungs, in the brain, in the liver, sometimes infect the kidney. So they're much more serious fungal infections. And tuberculosis, even though it's a mycobacteria, so myco is fungal bacteria, we've done that already. So it has some similarities that can also infect these organs as well. Okay, so let's just remember superficial, the hair, nail, skin, same as cutaneous. For systemic fungal infections, there's usually something happening with the immune system, and that's why the fungal infection has managed to cause the infection within the lung. And we use oral antifungals to treat them, since topical antifungals cannot treat a systemic or a deep fungal infection, versus superficial fungal infections where we can use different creams, such as you see on this slide. I mentioned mycostatin. Ketoconazole comes as a cream, and ketoconazole also comes as an oral tablet for deep fungal infections. And another one that we're going to talk about for deep fungal infections is amphotericin. And lastly, opportunistic infections or fungal infections. So any opportunistic infections means that the infection is occurring because of a weakened immune system of the patient, and the infection is taking the opportunity to grow within the patient due to the weakened immune system. Okay, so I won't spend too much time on this slide. I would really try to break it up into, so the first two, superficial and cutaneous, are essentially the same. We're talking about skin, mucous membranes such as the vagina or the mouth. Nails can get infected with fungal infections, and the scalp can get infected with fungal infections. The deeper ones, we'll just call them deeper, are, say, subcutaneous and systemic within an organ somewhere in the body. And they're much more serious. They need oral medications. And finally, the opportunistic fungal infections. Typically, we're looking at patients that are immunocompromised from either chemotherapy or, say, bone marrow failure from a cancer, or many other diseases that cause compromised immune system. So we're going to talk about two oral antifungal medications. And just remember, the oral antifungals are used much less frequently than the creams, since many of us can develop superficial fungal infections of the skin due to the climate we live in, due to activities that we do. Sweat is a great place for fungus to thrive, in folds of skin that I've spoken about before. So the first one is ketoconazole, or the brand name is Nizoral. And ketoconazole comes as a pill for deeper systemic fungal infections, and it comes as a cream for superficial fungal infections of the of the skin. And some of you might recognize it actually as a shampoo as well, because it comes as a scalp lotion. Because dandruff is actually a form of a fungal infection. We now know that dandruff is caused by a type of fungus, and we can treat severe dandruff with antifungals. So if someone came in with severe dandruff and was looking for a treatment, ketoconazole shampoo would be very effective for them to treat their flaky skin or their flaky scalp. Okay, so ketoconazole, antifungal medication to treat a whole number of different fungal infections, whether as a cream or as a pill. The action, it inhibits the cell membrane of the fungus. I don't think we need to go into more detail. What are the adverse effects of oral ketoconazole? Not so much the cream. Well, definitely hepatitis is an adverse effect of ketoconazole. Because it's produced with a type of steroid ring in it, ketoconazole can actually cause some gynecomastia, so breast enlargement in men. You're going to see this in a number of other medications, but ketoconazole is one of them, so mild breast enlargement, since it has some anti-androgen effects. So if you have an anti-androgen effect, meaning you're blocking testosterone in the body, you're allowing the small amounts of estrogen that are in males to have more effect, and males can get small breasts. In females, you can get irregular periods. And remember, these are all from oral ketoconazole. Okay, so why can you get irregular periods in women? Well, remember, ketoconazole has anti-androgenic effects. It's messing around with the steroid-based hormones such as estrogen, progesterone in women, so it can cause irregularities in the period. Contraindications. So we see that there's potential to prolong the QT interval on the cardiac rhythm. So ketoconazole, basically that tells you this drug doesn't get along with many other drugs because it's prolonging QT, which can be caused by many other medications. So I don't think you need to memorize every drug that causes a prolongation of the QT. It's impossible. Okay, renal failure. It's excreted by the kidneys, so renal failure would be a reason to avoid this drug. It's typically given orally. Very rarely is it used intravenously, and also can be used as a cream for superficial fungal infections and, as I mentioned, dandruff. So we would definitely monitor liver function tests in someone who is using this orally, especially if they're having to use it for prolonged periods of time. And just remember the signs to mention to someone if their liver is in trouble with a medication. So they'll have dark urine from the bilirubin that's now pouring into the urine instead of being processed by the liver. They'll have yellow eyes. They can have right upper quadrant pain. They can have bruising if the liver's in trouble. Their stools can be clay colored or very beige in color, since if bilirubin isn't being processed and excreted into the gastrointestinal tract, well, that's what gives stool its color. So absence of bilirubin will cause clay-colored stools. Okay, so amphotericin B is an intravenous antifungal. And it's a bit of a nasty drug. It has a lot of side effects, and we very rarely will use it. So it's really for severe systemic fungal infections. It doesn't come as a cream, and again, it damages the fungal cell wall. So what are the effects? Well, you can get phlebitis at the IV site. It's severely nephrotoxic, and it's toxic to the bone marrow as well. You can also develop an infusion reaction that we'll talk about shortly. So there's no specific contraindications to it, except, of course, if you have significant kidney disease or renal failure, we would be extremely careful before using amphotericin, since we already know that it's nephrotoxic, and it would harm the kidneys even further. So in terms of nursing considerations, well, IV hydration prior to this medication, so that's telling you how toxic this is. We need to pre-hydrate or provide IV fluids prior to the drug to make sure that the kidneys are functioning well, are flowing well, and that the drug can be excreted properly. Monitoring of CBC. Well, that's from the bone marrow suppression that can be caused from this medication, and monitoring of renal function because it's nephrotoxic. Patients will often say or tell you that they have a painful arm where the IV is running due to some inflammation of the vein called phlebitis. Now let's talk about the IV infusion reaction. So amphotericin is usually infused over a span of 2, 3, 4 hours. If given too quickly, you can get an infusion reaction of fever, chills, and rigors during the transfusion. So a test dose can be given of a small dose of amphotericin, 1 milligram, that's infused slowly to see if there's any reaction to the medication. As well, Tylenol can be given, and also diphenhydramine as an antihistamine to offset any fevers or allergic reactions that can occur during the administration of amphotericin B. Now, when I look through the ATI book, I can see many types of antifungal medications. Just below antifungals, I can see flucytosine, nystatin, miconazole, clotrimazole, and so on. And I don't think it's possible to know every antifungal. I would really try to concentrate on the prototypes and maybe just take a look at the list. And then the other part is are the interactions with an assortment of different medications. And I think a good way to approach this is to realize that antifungals as a group, whether it's ketoconazole or amphotericin B, really don't get along with many medications. We would have to look into a handbook to make sure prior to giving other medications, since antifungals given orally or IV can cause significant interactions with so many drugs. So I think it's more important to try and get the concept of deep systemic infections and certain antifungals such as ketoconazole and amphotericin versus superficial infections where antifungal creams can be used, as opposed to trying to memorize all the drug interactions, since it's just not possible. Okay, what about nystatin? So that's one of the other ones that you've seen on the list, and we'll just briefly talk about it. We use it a lot for oral thrush, candidiasis, So that's a yeast infection, and it's lumped in with the fungal infections. We can use it for vaginal candidiasis as well. It comes as an oral solution that you can put in children's mouth to clear the thrush, and it comes in an assortment of vaginal creams or suppositories that can be put in to treat a vaginal yeast infection. It destroys the fungal cells. I don't think we need to go into a lot of detail. There's really next to no side effects since you're using it in a topical sense or in a solution for the mouth. Elderly patients that get recurrent oral thrush can soak dentures in a nystatin solution. As I said, it's very common to use this in children that have acquired thrush, or someone that's been on antibiotics and now has thrush or yeast vaginitis. Okay, so this one just goes through, these are superficial skin, fungal skin infections. So they're called dermatophyte infections. Derma being skin, and phyte being fungal infections. And the first one, athlete's foot, we mentioned tinea pedis. So tinea is fungus, pedis is foot. Nail infections, tinea unguium, which is the nail. Ringworm of the body is, I'm not sure why we call it ringworm, it's really just tinea corporis. Ringworm in the groin is tinea cruris, and finally, if it's on the scalp, it's tinea capitis. And most of them are very treatable with topical creams, except sometimes tinea capitis. It can really get deep into the scalp, and that sometimes requires an oral antifungal. So we've already mentioned the first definition here, dermatomycosis being a superficial infection, fungal infection of the skin or the hair, and we call it tinea. When it's a fungal infection of the nail or the nail plate, we call it onychomycosis. Okay, and you'll see this very frequently in elderly patients and sometimes even in young patients, that they just get a fungal infection of the nail bed, the nail itself, and they're very hard to treat. They often don't resolve by just using creams since it's really into the nail, and often they need an oral antifungal for many weeks or months to clear the nail bed or the nail infection, sorry. Since your average nail takes about 3 months to grow out, you have to be on an antifungal for around 2 to 3 months to let the nail grow out and a normal nail take its place. So many times we don't treat these since in elderly patients it doesn't spread anywhere else, it just stays on the nail, and taking an oral antifungal medication for that long can be quite toxic. And here's an example of one that can be used called terbinafine, which is Lamisil. And Lamisil, terbinafine also comes as a cream for all those superficial infections, and it comes orally for something like onychomycosis. Okay, here's some superficial fungal rashes. Tinea pedis, which is athlete's foot, often between the toes, and onto the dorsum of the foot there. Ringworm, that's tinea corporis of the body. It's often circular with a central clearing, and that's just the gradual expansion of the superficial fungal infection on the skin. And then tinea cruris, again, you can see 2 folds of skin there, so it's a perfect place for fungus to grow, and we would call that jock itch or a jock infection, or well, tinea cruris is the medical term. Okay, so on this slide, that's a view of oral thrush on the tongue. It's often in the back of the throat on the soft palate where the uvula hangs down. So that's a common place as well. But the tongue, and it can be quite painful to swallow for children. Now, in adults, it's very unusual to have oral thrush. It is possible with a cortisone or what's called a steroid inhaler that we haven't covered yet, that locally immunosuppresses the mouth, and you can get thrush from that inhaler. But otherwise, it's usually an indication that you're immunosuppressed in some way, whether it's diabetes or HIV, chemotherapy, or as I mentioned, a cortisone inhaler can do it because of the steroid in it, or previous or recent antibiotic use because the yeast has become colonized in the back of the throat since you killed off some bacteria. And the treatments, so there's an oral solution of antifungal nystatin. There's one called clotrimazole, and there's a medication called fluconazole, which I've been referring to as diflucan. Sorry, that's the brand name. Fluconazole is actually the generic name that can be used orally to get rid of whether it's oral thrush or yeast vaginitis. Okay, so we're finished with some antifungal medications, and we're going to go on to some parasitic infections, which typically are composed of protozoa and worms, intestinal worms. So who gets protozoal infections, which are in the parasite category? And we're going to have to go pretty fast here because there aren't that many medications, and some of this you get in pathophysiology for sure. So travelers to developing countries, potentially eating contaminated food or water, patients that are immunosuppressed are wide open to an assortment of infections, including protozoal infections, HIV, since you're immunosuppressed, and of course cancer patients that are either immunosuppressed from the cancer itself that's invading the bone marrow, or the chemotherapy agents that they're taking to treat their cancer. Okay, just briefly, because it's really hard to talk about a medication with no background to it. What's a protozoal infection, or what are protozoals? Single-celled organisms that live in water and soil or animal hosts. They often live very well in poor sanitation, dirty water, poor hygiene, so areas of poverty and very high density populations. So it's a very common cause of worldwide deaths, different protozoal infections that we're going to come to. Malaria is a big killer worldwide. Amoebiasis is an intestinal protozoa that you get from consuming dirty water, and we can talk about that. Trichomonas is a protozoa, typically a vaginal infection. It's sexually transmitted often. And Giardia is in the same group as amoebiasis. It's an intestinal protozoa that both of them can give you diarrhea, abdominal cramps, lack of appetite, and we'll talk about a treatment for those. Okay, so here we are at metronidazole for protozoal infections that we've just gone over a couple of them, such as Giardia and amoebiasis. You can also use it for what's called bacterial vaginosis. Bacterial vaginosis actually is an overgrowth of bacteria in the vaginal canal. Trichomoniasis is a specific protozoal infection that's sexually transmitted that also responds to metronidazole. And we also use it in, this will be in other modules, but it's actually used in combination with other medications for peptic ulcer disease and other anaerobic bacterial infections, meaning bacterial infections that do not require oxygen to survive. But in this module, we're talking about it from the point of view of parasitic infections. How does it work? Disrupting DNA of microbial cells. What are the main side effects? Okay, by far the main side effect of this antibacterial or antiprotozoal is nausea and vomiting. People can get a metallic taste in their mouth, but I'm going to tell you most people have nausea and gastrointestinal upset with metronidazole. We warn people about it. Contraindications. Well, definitely alcohol use is a contraindication, and we'll come to that in a minute. There is the potential to aggravate seizures, and it's avoided in the first trimester of pregnancy. But we're going to talk about nursing considerations for alcohol consumption. So patients that are taking metronidazole need to be advised that they cannot have a drop of alcohol. There's a significant interaction with metronidazole and alcohol, where they get what's called a disulfiram reaction. So disulfiram is a medication that was used to deter alcoholics from consuming alcohol. So you'd give them a prescription for disulfiram. The brand name is called Antifungals. And if they consumed alcohol while taking this drug, they would have a violent reaction to the alcohol, which was supposed to deter them from taking the alcohol, which was a bit strange because you could actually just stop the disulfiram and then carry on with consuming alcohol. So it didn't really make a lot of sense. It's still available, but used very infrequently. But you can get the same reaction with alcohol and metronidazole. So we call it a disulfiram reaction. So we strongly recommend people not to have alcohol with this particular medication. And if they do, it's likely they're going to get some violent symptoms, gastrointestinal symptoms in particular. So that is a definite piece of advice that you need to give the patient. And I would say that's the most important. Now, you can get some darkening of the urine with metronidazole, but that's harmless. That's not going to cause any symptoms. It's just for them to know. Metronidazole can mess with warfarin in terms of elevating the effects of warfarin, so increasing the INR levels, which means increasing the thinning effect of the blood, which can lead to gastrointestinal bleeding. So monitoring the INR. Okay, going along here quickly, amoebiasis or giardiasis, they're both protozoa. They're not identical, and you can get this in North America, United States, Canada, anywhere where there's poor sanitation or contaminated water. So if you're hiking on a trail somewhere and you drink the water that has contaminated water upstream, such as contaminated with beaver dams, beavers are good vectors of giardiasis. And if you drink the water, you can get, they're good vectors of giardia, and you can develop giardiasis. Amoebiasis is the same. So they're infections of the intestines. They often cause miserable diarrhea, belly cramps, lack of appetite. You really do feel miserable with these. And they're spread fecal orally, meaning dirty hands. So someone has a bowel movement, their hands are dirty, they touch someone else, or they contaminate an area, someone else touches that area and touches their mouth, and they now have amoebiasis or giardiasis. So here's the organism that causes giardiasis, Giardia lamblia. It's a parasite. What's the major symptom? Definitely diarrhea. Entamoeba histolytica. I love these terms. That's the organism that causes amoebiasis. Again, we're talking about um, protozoal infections here. And what's the major symptom? Diarrhea. Sometimes Entamoeba histolytica can actually travel through the bloodstream to the liver and set up some living areas in the liver and develop liver abscesses. Trichomonas, so the disease is trichomoniasis, and it's a vaginitis in women. And we'll talk about the fact that it's a sexually transmitted disease and what we can do about it. Okay, so I'm not going to spend too much time on giardiasis, other than the fact that it's similar to amoebiasis. It causes diarrheal symptoms. It's obtained through dirty, contaminated water. The symptoms can last for weeks and weeks until you treat it. And we diagnose it with a stool specimen for protozoa. So we can do bacterial cultures on stools, we can do parasitic cultures on stools, and we can check stools for Clostridium difficile toxins. So all kinds of ways of finding out what the infection is. And the treatment for this is a medication called metronidazole, which, as I mentioned before, is an antibacterial and an antiprotozoal medication. And people usually take it orally. It can be given IV if people or patients are vomiting, but for the most part it's taken orally. Amoebiasis gives similar symptoms to giardiasis, but just more severe. You tend to have more abdominal cramps, more diarrhea, and as mentioned, this can spread to the liver and have a parasitic infection within the liver. Here's some information on amoebiasis. The treatment is the same. It's often with metronidazole, and we'll just keep on moving here. So just some information for you before we get to the medications. Okay, so trichomoniasis is a sexually transmitted parasite for the most part. It can affect men or women, but typically it's women that tend to develop a lot of symptoms that bring them in for assessment. So as mentioned, it's spread through sexual contact. The women's symptoms are mainly a yellow-greenish vaginal discharge. It's really quite foul smelling. It has a fishy smell to it. And they're often quite uncomfortable in their lower abdomen. And we can diagnose this with vaginal cultures, and often just from an examination, you can tell that it's trichomoniasis, and there's treatment for trichomoniasis as well, which is again metronidazole. So metronidazole comes as a vaginal cream, or usually what we'll do is treat women with oral metronidazole, since that will also clear it up. Okay, so we're going to start a completely new subject: viral infections, HIV, and then the development of AIDS from HIV infection. So this slide is showing you basically a viral particle and how it attaches to a host cell. Remember that a viral particle is really just a little bit of RNA or DNA that's encapsulated, that then has to use the host cell and all its organelles in order to replicate. And then after replication, the new virions are assembled and packaged and released, and they go to new host cells. So viruses are amazing. Not only do they infect us, they actually use our energy and our own organelles and our DNA and RNA to produce the proteins that they require to synthesize new virions that are then released to continue the viral infection. So I realize some of this has been reviewed in pathophysiology. Never hurts to get a couple minutes on a reminder. So what is a virus? A microscopic infectious agent. It's the most common infectious disease that humans acquire. All the different viral infections. Luckily, most of them, do not kill us. Our body and our immune system can usually fight the viral infection and clear it. So it requires living cells to replicate, and it uses host cell organelles and basically the factory of each cell to make new virions. Amazingly, certain viruses can learn to adapt to the human immune response, meaning certain viruses can mutate so that the immune system is constantly trying to find new ways to attack the virus. But if the virus keeps ahead of the immune system in terms of mutating, it can avoid being destroyed. And lastly, viruses are definitely more difficult to treat than bacteria. We have many antibacterial medications. We have very few antiviral medications that are effective and can completely rid the body of the viral infection. We have some antivirals that can slow down a viral infection, and we'll discuss those coming up shortly. Okay, just some ongoing concepts here. Again, I know this is in Pathophysiology 1, but the more you hear it, whether it's in the setting of pharmacology or pathophysiology, it's all part of the information that you'll need going forward. So viruses can mutate rapidly, making even antiviral therapies ineffective. And there aren't that many antiviral therapies. So there are some, but nothing compared to the antibacterial therapies that we have. They're tiny organisms, much smaller than a bacteria. They can lay in a latent form, or they can be in a latent form in the body for many months to years, where there's no active infection, but the virus is still living in the body. So an example of that would be the chickenpox virus that lays dormant in your dorsal root ganglion and then presents later on in life as herpes zoster, which is shingles. So, and other viruses can also do this. So there's a virus that causes mono called the Epstein-Barr virus, EBV, and this could stay latent for years and then be a cause of a type of cancer called lymphoma later on in life. As mentioned, viruses require a host cell to replicate. They can't replicate on their own, so they depend on us as humans to replicate. They need our cells. And viruses can give a variety of symptoms depending on what they're infecting. So if they're generally infecting the respiratory system and the nasopharyngeal tract, well, that's going to be typically a common cold virus. But there's many other types of viruses. There's some that can infect the brain itself, leading to encephalitis, which is inflammation of the brain. There's viruses that can cause infectious diarrhea. So we would call that a viral enteritis. And all of us have had viral enteritises where we've had a day or two of vomiting, nausea, and diarrhea. Antivirals, they definitely have a very narrow spectrum of activity. They're usually effective for a very limited number of viruses, and we'll come to that. And rarely do they have any ability to cure and clear the body of the viral infection. So luckily, most viral infections are self-limiting. They don't require any treatment, including antibiotics, because antibiotics don't work at all for viruses. And most of them resolve within 7 to 10 days by the body's immune system clearing them. Okay, so this slide is just giving you an idea of some antivirals and some conditions that they're used for. So acyclovir, we've spoken about that it's used for herpes simplex 1, which is usually an oral labial herpes of the lip. Herpes simplex 2, which is a genital herpes. Herpes zoster, which is the reactivation of the chickenpox virus that lives in the dorsal root ganglion. And finally, under certain conditions, we use antivirals, acyclovir in particular, for chickenpox. Okay? Ganciclovir is another one, significantly more toxic, not used as commonly, and really the main one is cytomegalovirus. For the most part, cytomegalovirus has no impact on a healthy human being. In fact, you probably wouldn't even know that you have it. But in certain populations that are immunosuppressed, such as HIV, you can get cytomegalovirus infections. In particular, in HIV, it can affect your retina, leading to blindness. And also organ transplant recipients. They need to be treated with very powerful immunosuppressants so they don't reject the organ transplant, and they can be at risk for cytomegalovirus, and they sometimes require ganciclovir. Okay? Interferon is actually a cytokine that's made in the inflammatory system of your body naturally, and the laboratory scientists have taken advantage of that and can now produce it in the lab. So interferons can be produced, and interferons, which are cytokines, activate the immune system. So they're immune boosters. Okay, so they increase the immune system to respond to potential infections, and in this case, they're used for hepatitis B and sometimes for hepatitis C. Remember that there's actually now a cure for hepatitis C, and if you don't remember that, that's fine, because we have other modules where we'll discuss it. An example of an HIV medication, lamivudine. We'll get into many HIV medications coming up. This is just an example where this one is specifically used for HIV. So it's not like every antiviral can be used for any viral infections. There's specific ones. Oseltamivir, you'll probably know it by Tamiflu, and this is used for the flu. So influenza A, which is definitely the more serious influenza strain, the one that causes pandemics, the one that kills thousands of people annually, especially in the winter, and can also be used for influenza B. Ribavirin is another one. just another antiviral that can be used for a, a viral infection called respiratory syncytial virus. And this is the virus that causes bronchiolitis in small children. So the virus in the winter that causes wheezing and runny nose and short of breath in these little infants. And they can become actually quite ill with this virus, especially if they're premature and they acquire this virus. And they're often we often see them in the winter, and they're just pouring mucus out of their nose. They're wheezy, they're coughing, and that's called bronchiolitis. So sometimes ribavirin can be used for that. So this is just a sampling of some ones that you may come across in the ATI book, and these are the reasons why we use them. Okay, so let's come to our first prototype drug for antivirals, and acyclovir would definitely be the prototype for this group. It's been around the longest. Unfortunately, acyclovir it requires 3 to 4 times per day of dosing. So other ones have come out that are easier to take with less frequent dosing, such as famciclovir and valacyclovir. They're basically the same. They're in the same group. They're used for the same conditions. So when do we use acyclovir? Well, for herpes simplex infections. So that would be, say, herpes simplex as a cold sore, which is herpes simplex 1, or herpes simplex 2, which is genital herpes. And that can be in males or in females for either herpes simplex 1 or 2. Now, herpes simplex can cause even more serious infections. It can actually infect the brain and lead to herpes encephalitis. And in that case, we would definitely use some form of acyclovir or famciclovir in an intravenous form for someone who presents and is diagnosed with herpes simplex encephalitis. But by far the most common ones, or the reasons for using acyclovir or one of its similar drugs, is herpes simplex as a cold sore or genital blistering herpes. The other indication is shingles, so varicella zoster viruses. So that can be chickenpox. If you develop chickenpox as an adult, we will sometimes use acyclovir, or after its latent form, and then it represents later in life as herpes zoster, which is shingles. We use one of the antivirals in this group to treat shingles if they present within 72 hours of having the rash come out. After 72 hours, it's not very effective. So what does it do? Well, this group of medications, the acyclovir group, prevents the replication of viral DNA, and so reduces and interrupts the replication cycle of the virus. Really has minimal side effects when given orally. It might cause a bit of vein irritation, phlebitis, if given intravenously, but they're very safe medications. Intravenously, we would avoid it in patients with severe renal failure. Otherwise, it's well tolerated. And administering the drug as soon as the symptoms occur is best, because once the virus has had time to replicate many times, the antivirals aren't very effective. And that's why with herpes zoster or shingles, really after 72 hours, there's no evidence that there's any effect to use one of the antivirals in this group. Okay, we just spoke about this on an earlier slide. I'll leave this slide to you. It's all about HSV1 and HSV2, and the treatment is the acyclovir antiviral group. Okay, and this is classic herpes simplex 1, cold sore, and this is a chronic recurrent condition. It'll blister on the lip and then heal only to return months later after it's been dormant or latent for a period of time. So the earlier, assuming that you do want to treat this, because even if you don't treat this, it will still go away. So assuming that you do want to treat it, the earlier you can get the antiviral medication into your system, the more chance you will have to clear the viral infection more quickly. Okay, and this is just showing the stages of herpes simplex virus 1. So oral herpes. By the way, um, at any one of these stages, you're potentially infective to somebody else. Most of us acquire cold sores in childhood from either sharing of cutlery or glasses or being kissed on the lips with someone who has a cold sore. Okay, and here's genital herpes simplex virus. It can be on the shaft of the penis in males. It can be on the vulva externally in females, and it can be inside the vaginal area in females as well. So what causes HSV to be recurrent? Well, the virus actually never gets cleared. It remains in the nervous system only to be reactivated by either an illness or fever or stress or immunocompromised. And sometimes we never know what caused it to be reactivated. So this is definitely a sexually transmitted disease. And usually it's the first infection that's the most severe. So whether we're talking about herpes simplex 1 or herpes simplex 2, the most severe episode is typically the primary infection. Okay, so I'll leave this slide for hopefully an in-class discussion. You can see the classic blisters in the right upper part of this slide, typically on the shaft of the penis and on the outer vulvar area or in the vagina or on the cervix in females. Okay, this is an image of another virus, so the Epstein-Barr virus, mononucleosis or mono. It actually looks very, very, very similar to strep throat. They're actually extremely hard to tell apart. This is a virus, and then of course strep throat is streptococcus. It's a bacteria. So sometimes we actually have to do throat swabs to see if it's strep throat, and a blood test, which is called a monospot test, to see if someone has mono. Now, if someone has mono, they often have other symptoms along with it. So fatigue, sore throat, very swollen glands in their neck. They often have an enlarged spleen, sometimes an enlarged liver. So there's often other symptoms or signs that tip us off that this is mono instead of strep throat, but they do look very similar. Now, by the way, we don't use antivirals for mononucleosis. They really haven't been shown to be effective at all. So really, this is just symptomatic treatment for this condition. Okay, and this is just another slide on mononucleosis, sorry. infectious mono. It's just going to give you some information on the most common age group, how you contract it, whether it's saliva, sharing of cutlery with a friend that has mono. It's known as the kissing disease. There you can see it's caused by Epstein-Barr virus. The sore throat is classic, headache, swollen lymph glands in the neck, and other parts of the body under the arms. So that's called the axilla, and in the groin you can have swollen lymph nodes. You can have right upper quadrant discomfort because your liver can be enlarged. You can have left upper quadrant discomfort because your spleen is often enlarged. And all the other symptoms that go along with a viral infection, the loss of appetite, the body aches. This particular virus can cause profound fatigue. We mentioned some of the diagnostics for this particular condition. So a monospot is that blood test. Sometimes if we think the liver is involved and we want to see how involved it is, we'll do liver enzyme tests. And I think that's usually the how far we go with the testing. We don't usually go a lot further once we've diagnosed mono. Sometimes if we're really concerned about the spleen, we'll do an ultrasound to see the size of the spleen and to give patients advice about avoiding contact sports for 6-8 weeks sometimes until the enlarged spleen has returned to normal. So really it's just symptomatic treatment. It's rest, throat lozenges, Tylenol, acetaminophen, and just low impact activity. There's no contact sports with this because of the risk of splenomegaly. And there's no antivirals for this either. Okay, so the next viral infection is chickenpox, also called varicella. It's a very contagious virus. So if children are in the same room with someone with chickenpox and they're not immunized, then they have greater than a 90% chance of also developing chickenpox. But now that there's an immunization for chickenpox, it's a much less common childhood disease. So it's caused by the varicella zoster virus, and it's classically a blistering rash, water-filled blisters all over the body, with fever and fatigue, and then of course itching of the rash. Okay, so this next slide on chickenpox. Here's a cute little kid in a healing stage of chickenpox. Some of them are obviously scabbed over. So we don't see this very often anymore because of immunization as a child, which makes acquiring chickenpox much less common. We do still use antivirals in chickenpox if you are immunosuppressed with a disease or because of medications that you're taking, and as well in pregnancy. So in pregnancy, if you have active chickenpox, we will prescribe acyclovir or one of its variants, such as famciclovir or valciclovir, to treat the chickenpox. If you're pregnant and you've been exposed to someone with chickenpox, but you don't have any disease, then we may consider giving you immune globulins, the antibody that fights the viral infection. So immunoglobulins are antibodies that we inject into someone to address a specific condition, such as the virus that can cause chickenpox. So if you're pregnant, you have the active disease, acyclovir. If you're pregnant and you've been exposed to someone with chickenpox, we can use immune globulin to try and prevent the the disease from occurring in the first place. Okay, and here's chickenpox as a younger person. This scenario is changing a bit because of the chickenpox vaccine. But here's on the left is someone with chickenpox, fever, headache, malaise is just a general feeling of just feeling awful, with a vesicular rash, so it's a fluid-filled rash caused by the varicella zoster virus. That's what causes chickenpox or varicella. And it's easily transmitted through respiratory secretions or the actual fluid in the blisters itself. Now, that person grows up. So the person on the right is the same as the person on the left. And that virus has been living in a latent form in the dorsal root ganglion of the central nervous system. And it can reactivate to become, the varicella zoster virus can reactivate to become herpes zoster at any point in the future. And it typically affects one nerve, so it follows what's called a dermatome on the body or on the face. So it's a pretty classic rash because it's a blistering rash, and it only follows one nerve root. So it never crosses the midline of the chest or the abdomen, since the nerve root only goes to the midline. Okay, so there's different ways of diagnosing it. One of them is definitely that it shouldn't be on both sides of the body at the same time, since it's only affecting one nerve root. Okay, so in pregnancy with chickenpox, immunosuppressed patients, whether they're children or adults with chickenpox, because adults can get a much more severe symptoms with the chickenpox or varicella. No need to remember these doses. We're not actually doing doses, but here's basically 3 antivirals. They're all in the same group: acyclovir, valcyclovir, and famciclovir. So you can see they all end in vir, and they all work the same way. They're all in the same group. It's just that acyclovir is 5 times a day, and it was very difficult to convince people to take it 5 times a day. So years ago, we came out with other ones such as valcyclovir or famciclovir. Okay, so in general, this is the treatment for chickenpox. We can use calamine lotion, since it's a weeping lesion. The blisters open and weep and crust. So calamine is a drying agent, and it's used for weeping or wet type lesions such as chickenpox. So it can help that. It can help. Antihistamines like diphenhydramine can be used for the itching. Oatmeal baths can be extremely soothing for the itch. So just putting oatmeal into a bath. You can buy oatmeal at the pharmacy, or you can actually put some oatmeal from the food store in a stocking and just put it into lukewarm water, and that can really help chickenpox. Cold compresses can also help the itch, and of course just loose-fitting clothing to avoid irritating the scabs. So both of these conditions, chickenpox and herpes zoster, are from the identical virus. So this particular virus has the ability to remain dormant. So after an infectious episode of chickenpox, it can remain latent and then be reactivated as shingles or herpes zoster along any nerve root. So it can cause a blistering, painful rash along any nerve root in the body. So if we look at the slide on the right, we can see chickenpox on the left, varicella, and herpes zoster on the right, which is unfortunately affecting the nerve root of this person's right forehead, which is not a very good place to get a reactivation of shingles or herpes zoster, since that nerve root also can involve the eye, and they can get scarring of the cornea called keratitis. So if you're going to get shingles or herpes zoster, it's better to get it along a nerve root of the chest or the back, or away from the eye, obviously, since it can cause scarring of the cornea. And definitely for herpes zoster, we will use an acyclovir type medication to treat it. Okay, these are just different images of showing you how herpes zoster or shingles is following one nerve root. You'll notice that it's never crossing the midline in any of the photos. It goes in the lower left, it goes to the umbilicus. In the upper right, it goes right to the sternum, but doesn't cross the midline since the nerve ends there. Okay, I think we've covered most of the information on this slide already, but let's just make sure that we're all on the same page. So herpes zoster lives in the dorsal root ganglion. So when it's activated, it just affects a single dermatome along the skin. It's typical. It can occur at any age, but by far the majority are after the age of 50. And why would that be? Well, the immune system is gradually getting a bit weaker, less robust, and the herpes zoster can be reactivated as the immune system gets slightly weaker. I mentioned that herpes zoster can affect the eye if you get the reactivation in that nerve area, which can be very serious. That's probably one of the most serious issues with herpes zoster when it is around the eye. And of course, as with chickenpox, herpes zoster in an immunocompromised patient is much more serious. It can make them much sicker. In fact, what can happen is the virus can become more systemic or disseminated. Disseminated just means it's spread throughout the whole body, and they can develop, as I mentioned before, an encephalitis. So you can get a viral or a herpes encephalitis from herpes zoster if you're severely immunocompromised. For the most part, it just stays at one dermatome, and we treat it with an antiviral such as acyclovir. Okay, so continuing with shingles here, we've discussed the pharmacotherapy. This is just some more information on shingles. So often after the age of 50, but can occur at any age. So you can be 20-year-old and get shingles. And over the age of 85, it becomes even more common just because our immune system is gradually weakening. And often even before the rash comes out, your symptoms begin with burning, tingling, numbness from the nerve that's becoming inflamed, even prior to the blistering rash. And then, of course, the blistering rash comes out, and we realize, yes, you have shingles now. So sometimes it's very difficult before the rash comes out to know whether it's shingles. Often the acute infection lasts for 2, 3, 4 weeks, and then scabs over, resolves. The sooner you can get acyclovir or one of its variants, such as famciclovir or valciclovir, into the system or into the patient, the better. And the reason for that is not only that it can reduce the severity and the duration of how long the patient has it, because often it just reduces it minimally. So you might have the duration reduced by a day. But what it really is intended for is to reduce what's called post-herpetic neuralgia, which is the long-term chronic pain that some patients can be left with even after the acute infection has disappeared in a few weeks. And it can be very disabling because of all the pain that's occurring. So the antivirals are intended to try and reduce the post-herpetic neuralgia symptoms. And we know that if it's given within 3 days, and even in that 3 days, if it's given very early in that 3 days, say right when the rash comes out, you can prevent uh, the uh, the complication of post-herpetic neuralgia and chronic pain in the area. Sometimes we'll use non-steroidal anti-inflammatories. They're not overly effective for nerve pain. Corticosteroids are anti-inflammatories as well. So one's non-steroidal anti-inflammatories, and of course corticosteroids are steroidal anti-inflammatories. And they can reduce the inflammation a bit, but they're not very effective. They don't stop the virus from replicating like acyclovir does. Okay, so let's just change to a different virus, one called cytomegalovirus, CMV. It's also a member of the herpes virus family, and the biggest issue with this virus is transmission to the fetus. So in general, when a healthy patient gets it or a healthy person gets it, it's typically quite harmless. But when a pregnant woman gets it and transmits it to a developing fetus, there can be significant congenital defects due to cytomegalovirus. Okay, so we spoke about toxoplasmosis being most concerning um, in pregnant women. Well, cytomegalovirus it falls into that group as well. So acquiring cytomegalovirus during pregnancy and transmitting it to the developing fetus is the most concerning feature of this particular virus. Since a small percentage, most will still be born with no symptoms, but approximately 10 to 15% will be born with congenital symptoms. So what are those symptoms? Well, they can have the CMV infection in their eye, in the retina. They can be much smaller. Um, there can be much slower growth, so gestational size can be much reduced. They can have small brains, microcephaly. They can have enlarged spleens and livers, and they can be jaundiced, so yellow, with bruising and blood spots all over their body. So for infants that are born with symptomatic cytomegalovirus, the treatment is an antiviral. It doesn't cure it. It tries to slow down the viral replication, and it's called ganciclovir. We're not going to have a prototype slide on it. I think it's important just to know about CMV and the fact that it can lead to blindness, it can lead to hearing loss and developmental delay. Okay, so cytomegalovirus is somewhat preventable. As I said, it's pregnant women who want to avoid getting this particular virus, especially early in pregnancy when the fetus is developing. And young children can often have cytomegalovirus without really anybody knowing. So avoiding the sharing of saliva, of cutlery, kissing on the lips, because they're at the highest risk for actually having cytomegalovirus that can then be transmitted to a pregnant woman and lead to fetal uh, defects. So high-risk places would be centers. Many toddlers carry this virus, and frequently washing your hand uh, during pregnancy, or really if you're not pregnant for other infectious diseases, and not sharing utensils, toothbrushes with younger children.
Okay, so we've spoken about an antiviral before. Ganciclovir is an antiviral that's used for cytomegalovirus. Okay, so where do we see or hear about cytomegalovirus? Well, it's one of the infections that can affect pregnant women and cause a lot of damage, a lot of fetal injury, and you'll see that on an above slide. Immunocompromised patients, such as HIV patients, can get cytomegalovirus in their retina that can lead to blindness. And this antiviral is also used for treatment of HIV retinitis. So ganciclovir. Okay, I think if you're just recognizing it as an antiviral and what it could be potentially used for, typically CMV, I think you're doing well. Okay, and remember, I don't think you can remember everything about every drug. Okay, it works the same as the other antivirals. It prevents um, uh, viral replication. Okay, it inhibits viral replication. So whether we're talking about famciclovir or valacyclovir for as an antiviral for herpes zoster, shingles, acyclovir for HSV1 on your lip or genital herpes. Uh, this again works the same way to stop cytomegalovirus from rapidly dividing. Okay, it also has a similar side effect of bone marrow suppression. So I think if you understand, just you recognize what the drug is for, what the indication is, how it works, I think you're doing fine. Always remember common side effects and severe side effects. It's not possible to remember every drug that causes a headache because they all do, it seems. But remember the common side effects of drugs and the severe side effect of a drug.
Okay, so let's change gears a bit here. Influenza. There are some antivirals that are used for influenza that I'll list on an earlier uh, slide. I don't think there's any need to do prototypes for all these antivirals. So the symptoms of influenza, it's like a really, really bad cold that's knocked you down. So sore throat, coughing, fevers, chills, muscle aches, weakness. Often young people can end up in bed. They're just floored by this infection. It's typically transmitted by airborne droplets or hand-to-hand contact, so direct contact, in immunosuppressed patients, and that would also include elderly patients in long-term care facilities or elderly patients at home. It just happens to go through long-term care facilities very easily from person to person. So there's three types: influenza A, which is the most virulent, the most aggressive of the influenzas. It tends to cause the most symptoms, and it's the one that's responsible for pandemics. Influenza B, it's you tend to have less of these symptoms, and they're milder, and they don't typically cause pandemics. They don't spread and cause significant illness like influenza A does in patients. Okay, this slide is just some information about preventing influenza. Definitely the best way to prevent influenza is mass annual vaccinations of the population. And the influenza vaccine uh, isn't foolproof. So it doesn't cover 100% of the population from getting influenza. But even if it's a good match for that year, um, it will definitely prevent a significant proportion of deaths from influenza. So it's definitely a worthwhile uh, vaccination to get annually. And we base uh, what's in the annual influenza vaccine from predicting through research which strains are coming through the population for any particular winter. So that's how it's produced. There's inactivated vaccine, which is typically for uh, immunosuppressed patients, such as with HIV, and there's a live attenuated vaccine. So the inactivated vaccine, there's nothing live in it. The live attenuated means that it's going to create a bigger immune response in the patient, but we really like to avoid live vaccines in patients that are immunosuppressed or pregnant because it gives them more symptoms, and we just don't like injecting live but semi-altered viruses or vaccines into immunocompromised patients. So who should get the vaccine? So basically anyone over the age of 6 months, anyone with chronic diseases or conditions, pregnant women should also get the vaccine, long-term care facilities. Everyone in the long-term care facility should be vaccinated, and of course healthcare workers. Okay, so how can you prevent the flu? So we just spoke about the vaccination. There are vaccinations that are available annually, but there's other ways to try and prevent the flu, and these are just good general habits to prevent all infectious diseases. But definitely for the flu, um, just look at these points, and I think they'll make sense.
Okay, so oseltamivir, another antiviral. In particular, it's an antiviral used for influenza A, which is the more severe form of influenza, with significantly more symptoms than influenza B. Okay, so elderly people are prone to becoming very ill with influenza A. Okay, and there was a lot of excitement for this drug when it came out because the studies showed that it was very effective for influenza A and B. As time has gone on, it's become very questionable whether this drug actually is, is effective at all for influenza A or B. Okay? So typically, we're going to reserve this drug for patients that have influenza A or B that are at high risk for developing severe illness, okay, such as influenza pneumonia. Okay, so it's not everybody who has influenza A or B is going to get this drug. And the reason for that is because of the high incidence of profuse vomiting, nausea, and diarrhea. A lot of patients cannot tolerate this drug. Okay, so you can imagine an elderly patient trying to take this drug and they have profuse vomiting and diarrhea. It's not possible. Okay. Some patients can develop psychiatric side effects from taking this antiviral. So just remember, oseltamivir for influenza A or B, a lot of gastrointestinal side effects of nausea, vomiting, and diarrhea. Okay, definitely less effective than the annual influenza vaccination. Okay, it's a questionable treatment once you already have the disease. The best way is to prevent the disease with a vaccination.
Okay, so viral hepatitis. So as I'm sure you're starting to see that there's really very few antiviral medications to cure viral infections. So we're going to talk about one in this part that can actually cure hepatitis C. So there's three very common types of hepatitis: hepatitis A, hepatitis B, and hepatitis C. They're caused by different viruses, and they're transmitted in different ways. And of course, patients become infected with them by different routes. So we'll talk about that. But basically, I mean, there's other viral hepatitises, but these are by far the most common. And they get into the hepatocyte, which is the liver cell, cause inflammation, destruction of some of the hepatocytes, release of enzymes, which we call liver function tests or liver enzymes, into the bloodstream, and we can pick up abnormal liver function tests, and we can also test for the different viral hepatitises in order to make a final diagnosis. Okay, so let's just look at a slide on the comparisons of the three different types of viral hepatitis. So remember, all kinds of things can cause hepatitis. So diseases, cancer of the liver, drugs can cause hepatitis. So we're just talking about the viral hepatitises. So hepatitis A is definitely the most mild form of the three hepatitis, the viral hepatitises. And you get this infection from fecal oral transmission, meaning you've been in contact with someone who has hepatitis A, or you've been in contact with contaminated food or fluid that someone has prepared that has hepatitis A. It incubates, so the incubation period is the time where you do not have any symptoms, the incubation period. So it can be anywhere from 2 to 7 weeks, meaning you may have gone on a trip to another country and obtained hepatitis A, and you're asymptomatic for potentially 2 to 7 weeks upon returning home. So you don't know that you have it yet. Is there a chronic infection? Can hepatitis A stay with you for many, many years and cause a chronic infection? And the answer is no. Is there a vaccine for hepatitis A? Definitely. There's a Hep A vaccine. And there's no treatment necessary. We don't use antivirals or anything else for hepatitis A. It's symptomatic treatment only. Now, do you feel ill? Do you have malaise, lack of appetite, fever, right upper quadrant pain? Are you jaundiced? Sometimes nauseated? Sure, you can have all of those things. You can often have some dark urine from bilirubin spilling into your urine. Can your stools be a bit clay colored, a bit lightish, heading towards pale or white? Yeah, you can get all of those symptoms or signs. Hepatitis B is typically from either sexual contact which is one of the most common ways of obtaining hepatitis B. Uh, blood-to-blood transmission. So say a puncture wound, a deep puncture, when you're putting in an IV in someone who has hepatitis B, and then you have a deep puncture wound to yourself, you can obtain hepatitis B that way. Blood transfusions. There's a risk of hepatitis B. It's very small now because of the screening that are done at labs. And finally, mother-to-child transmission during pregnancy and during delivery. So the incubation period is much longer, 6 to 26 weeks. Is there a chronic state of hepatitis B? Definitely. A small proportion of patients can go on to have hepatitis B chronically. So they'll have a chronic hepatitis with chronically elevated liver function tests. And over the span of many, many years, that's going to lead to gradual weakening of the liver and finally cirrhosis, which is scarring and a very poorly functioning liver. Is there treatment available? There is. There's interferons. There's a number of different immune modulators that can be used, but there's definitely no cure. There's no antiviral that's used for hepatitis B to cure it. Hepatitis C, the most common way of getting hep C is sharing needles by far. There is a small chance of obtaining hepatitis C through sexual contact, but surprisingly it's relatively low. It's usually the sharing of needles for IV drugs that is how you contract hepatitis C. The incubation period, there's the numbers, 2 to 26 weeks. You can imagine 26 weeks is a long time to incubate a virus. Many people end up with a chronic infection, definitely greater than 50%, upwards of 60 to 70% end up with a chronic hepatitis C infection. Unlike hepatitis A, which doesn't have a chronic infection, and hepatitis B is a much smaller percentage of patients end up with a chronic infection. Most clear the infection with hepatitis B. So that's a serious problem, because if you have a chronic infection of hep C, you're going to have chronically elevated liver function tests. You're going to have a chronically inflamed liver, and these patients are often going to end up with end-stage liver disease years later and cirrhosis. And when you have end-stage liver disease, whether it's from hep B or hep C, because of all the inflammation that's occurred for so many years, you're also at risk for hepatocellular carcinoma, so liver cancer. So really the end stage of chronic hepatitis can be liver failure and cirrhosis, or hepatocellular carcinoma, which is primary liver cancer. Now there is a cure that's not very old that's available for hepatitis C. It can be very effective for certain strains of hepatitis C. And the brand name for it is Harvoni. The generic name is a combination of two antiviral medications. So the first one is Ledipasvir, and the second one is Sofosbuvir. Don't need to know these, just know that there is actually a cure for hepatitis C. Okay, and this slide is just showing you the 3 different viruses that affect the liver, or the 3 most common ones anyways. And hepatitis A and hepatitis B, we get vaccinated for. This is also reminding you, how do you get hep A? Well, it's direct contact with someone with hepatitis A, or contaminated food or dirty water. Hepatitis B, blood transmission, semen, vaginal fluid, so sexual activity. Hepatitis C, typically sharing of needles, therefore sharing of blood. And there's no vaccine for hepatitis C.
Okay, so let's just look at some drug treatments for chronic hepatitis. What's the virus that causes the highest incidence of chronic hepatitis? That's going to be hepatitis C. Okay, approximately 2/3 or more of patients with hepatitis C will develop chronic hepatitis. And chronic hepatitis results in end-stage cirrhosis decades down the road. Okay? So now, if you remember hepatitis A, that's a self-limiting viral hepatitis. So yes, you get inflammation of the liver. Yes, you have nausea and vomiting, and you're jaundiced, but it's self-resolving. You're not left with any chronic hepatitis like you can with hepatitis B, which is where you can develop a chronic hepatitis, but much less frequently than hepatitis C. Okay, so there's a lot of patients that have unfortunately acquired hepatitis C infection and are now left with chronic inflammation of the liver called chronic hepatitis. So how can we treat people? Well, there's interferon therapies, so injectable interferon that can boost the immune system. If you remember, interferon is an immunity booster. Okay, so that can be used to try and fight the virus in the liver with injections of interferon. There's also antivirals. Okay, and I think I would just recognize the fact that hepatitis C can be treated also with antiviral medications. And you'll see that these drugs on the right, they all end in VIR, okay? Because they're antivirals. Just like when we spoke about acyclovir, famciclovir, those are antivirals that can be used for herpes or herpes zoster or genital herpes. Well, these are used for chronic hepatitis C. Okay, so I wouldn't get into a lot of the deep details of all of these drugs. I don't think it's necessary. I do want to mention the last one, which is a combination of two antivirals, and it has a brand name of Harvoni. And this is really exciting because this combination antiviral can actually treat and cure patients from chronic hepatitis C. Okay, so some of the strains of chronic hepatitis C are now curable with Harvoni. Okay, these two antivirals. That's amazing. So I don't want you to get the idea that everybody with hepatitis C will respond to Harvoni. It depends on the genotype, the strain of the virus. Okay, but there's a good proportion of hepatitis C that can be cleared with this combination antiviral, which is fantastic because these patients will clear the virus and not go on to develop end-stage liver disease, which will require a liver transplant. Okay. Does hepatitis B have a cure? No. Hepatitis B can also be treated with interferon, but it doesn't have a cure. So if you have chronic hepatitis B infection, there is no cure for it. There's treatments such as interferon. But remember, with hepatitis B, we have very effective vaccinations. Okay, so to prevent hepatitis B in terms of a vaccination, yes, we have. Okay, We have vaccinations for hepatitis A as well. Okay. We don't have a vaccine for hepatitis C, but we happen to have a treatment and a potential cure for hepatitis C.
Okay, so let's move on to another important viral infection, which is HIV, human immunodeficiency virus, which leads to the disease of AIDS, acquired immune deficiency syndrome. So, like any other virus, HIV requires host cells to produce its proteins and to produce new viral particles that can then be released into the bloodstream of the patient. And HIV attacks a particular T cell called a CD4 T cell or a helper T cell. And by attacking helper T cells, what happens is that the cell-mediated immunity, which T cells are part of, is ravaged. It's severely injured and finally destroyed by the HIV virus. So we're going to talk about some treatments for HIV, which have definitely come a long way over the past 30 years. And there's still no cure for this viral infection, like most viral infections, but there's very effective treatments that can be used to reduce the viral replication to undetectable levels in the bloodstream. So antiviral medications, antiretroviral medications for HIV are used in specific combinations of 3 or 4 medications to reduce the chance of resistance occurring with the HIV virus. So multiple steps in the process of where HIV infects the host cell, leading to viral particles, can be inhibited by different groups of medications. Okay, so that's important to know that when treating HIV, multiple steps, multiple medications need to be used at the same time. Otherwise, resistant strains of HIV appear very quickly. And the advantage of using multiple medications at the same time is not only reducing the viral load, the viral quantity in the bloodstream, but it's also improving the numbers of healthy T helper cells, the CD4 cells, since they're not being destroyed by HIV. So there's 2 particular tests that are checked for when patients are returning to clinic for follow-up and assessment of their HIV. And that is their CD4 count, which is usually, in a normal person, above 500. So usually 500 to about 1600 is a normal CD4 count. Once it gets below 500, patients are at risk to start acquiring opportunistic infections, and we'll get into some of those a bit later. They're at risk of acquiring a whole host of infections and also at risk of developing certain cancers because their immune system is so compromised. The other test that's done at HIV clinics or hospitals is the viral load. So that's a blood test as well, and it detects the RNA of HIV in the bloodstream. And the plan, when on 3 or 4 antiretroviral medications, is to get the viral load to undetectable levels, which then allows the CD4 cells to start to recover to normal levels. Okay, so those are the two tests that you're going to hear in terms of somebody's immune system when referring to HIV infection. CD4 counts and viral loads. So the higher the CD4 count, the better, and the lower the viral load in the blood, the better. So concepts are important in HIV. There's many medications. We're going to go through the different steps of how HIV infects a cell and where along the way medications are used to impact and reduce viral replication and production of new viral particles. And as I said, this takes 3 or 4 medications. If a patient is on one medication, blocking one step, HIV has an incredible ability to mutate, and it can easily become resistant to one medication. So 3 or 4 medications are used consistently, and they must be adhered to every day of the patient's life to avoid HIV-resistant strains. So that's a very important concept to remember, that lack of adherence to medication will result in resistant strains of HIV. Okay? So patients are strongly counseled on their adherence to medication regimens. Now, we're also going to talk about how we treat, in particular, a healthcare worker that's been exposed to potentially HIV-infected blood, and also a medication, an antiviral medication, that's used as preventative treatment in somebody who doesn't have HIV, but is at high risk for acquiring HIV, either due to their high-risk behaviors or having a partner who is positive for HIV. There's now a treatment that's available that a patient that is HIV negative can take to reduce their chances of acquiring HIV infection. Okay, so we'll chat about that on a later slide. The other concept that we'll talk about in the following slides is the fact that HIV is what's called a retrovirus. So it has RNA within the viral particle, and it uses an enzyme called reverse transcriptase. So all that means is that within the cell of the host, of the patient, the virus gets in. It now wants to convert its viral RNA to viral DNA by using an enzyme called reverse transcriptase. Why does it want to do that? It actually wants to insert itself into the genome, into the genes of the host's DNA. So by doing that, it can then control the host's DNA and produce its own proteins, which allows it to then produce further viral particles that can then get into the bloodstream and infect other CD4 cells. So, and the other really difficult thing about this virus, as I mentioned, is it has incredible ability to mutate. So this virus needs multiple attacks by different medications at different steps in its replication to really try and stop the viral replication and stop it from becoming full-blown AIDS. So what's the definition of AIDS? So HIV infection is you have the virus, you're HIV positive. AIDS is either when you have a CD4 count of 200 or below, which really means your immune system is severely impacted when your CD4 T helper cells are below 200. Or the other definition of AIDS is your first opportunistic infection. So if you are getting an opportunistic infection, these unusual infections in the setting of a normal immune system, once you start to acquire those, then we say that the patient now has AIDS. So it's either the CD4 count is 200 or below, or you are now getting opportunistic infections. All right, so let's look at how HIV and also many viruses get into the host cell and cause viral replication or lead to viral replication, release of many viral particles back into the bloodstream, leading to infection of other cells. And when we're talking about HIV, we're specifically talking about CD4 T helper cells, which, as I mentioned, are part of cell-mediated immunity, which is part of the adaptive immunity of the body, the part of the immune system that is responsible for recognizing previous infections and attacking since they have a memory to them. Okay, so there's the adaptive immunity B cells and adaptive immunity T cells. So we're talking about the T helper cells. All right, they're the ones that get infected. Let's have a look at how the drugs work. So the first, the bottom left, there are a group of medications called entry inhibitors. And entry inhibitors are really what they say. They try to block the virus, the HIV virus, from getting into the host cell. Okay? And there's fusion inhibitors and there's CCR5 antagonists. They do the same thing basically. They stop the virus from getting into the bloodstream, into the host cell, sorry. So they're broken up into those two groups, but essentially they're both entry inhibitors. And we'll come to that in a couple of slides. Number two are a group of medications that somehow impact the ability for the virus to convert its RNA to DNA. And the first group are NNRTIs, so non-nucleoside reverse transcriptase inhibitors. What does this group do? So all it does is it gets on to the reverse transcriptase enzyme and stops it from being able to accept the viral RNA and convert it to viral DNA by using its normal building blocks, which are nucleotides and nucleosides. So that's all it does. It just blocks the enzyme. The other group, which in a very similar fashion at the same site, are the NRTIs, the nucleotide reverse transcriptase inhibitors. And what do? Well, they don't directly block reverse transcriptase, but they pretend to be analogs of the different base pairs that go into making DNA. So they fake themselves into the production of viral DNA, and because they're not the real analogs, they're not the real nucleotides, the viral DNA is not produced normally. And we'll come to some examples of those. So there's two subgroups that mess with this part of viral replication. Okay, so let's go a bit further on. We go into the nucleus. There's an enzyme that's required called integrase. There are some medications for HIV that are integrase inhibitors. So they prevent viral DNA from getting onto or into the host DNA. And lastly, there are protease inhibitors. So let's just say that the virus was able to incorporate itself into the DNA. It then produced viral mRNA, messenger RNA, which can then go to ribosomes and produce viral proteins. Well, the proteins are inhibited. There's protease inhibitors that have an impact at this area that will stop protein synthesis, and that will reduce viral or new viral particles. Okay, so that's the basic. These are the areas of where HIV medications have their effect. Okay, so this is just the slide before, but in a bit more detail. This slide, there's no intention of memorizing this slide in terms of all these drugs. The concept of how these drugs work are more important, and just remembering the prototype drugs. So there's a host cell. At the top is where the HIV virus is trying to enter the CD4 host cell. And there's fusion and entry inhibitors. So fusion inhibitor or entry inhibitor, so enfuviratide or maraviroc. So these aren't easy to pronounce. One's a fusion inhibitor, the other one inhibits CCR5 protein. So it's an inhibitor and it blocks the HIV virus from attaching and getting in. So they essentially have very similar effects. Okay, so once the viral RNA is in, it needs to convert to viral DNA. And that's where you get into reverse transcriptase. And if you look at the left-hand side, you'll see that there's a list of drugs that will pretend to be thymidine, which is one of the bases for production of DNA. And zidovudine would definitely be the prototype in that group. Or there's a group of medications that can pretend to be cytidine. And I mean, it's amazing that these drugs were actually researched and developed. These drugs are tricking the reverse transcriptase, and it's incorporating these drugs in the production of DNA. So, and then of course the viral DNA is really ineffective because these drugs have been incorporated in the production of it, so it has no, it can't exert its effect. And then of course there's purine analogs, so guanosine and adenosine. So there's drugs that block or pretend to be those and get in and make a mess of the viral DNA. Okay, so that's the NRTI group. So the nucleoside reverse transcriptase inhibitors. Okay, good. The NNRTIs at the bottom there, they just directly inhibit reverse transcriptase. That's all they do. They change the shape of reverse transcriptase, making it impossible for the viral RNA to now be copied and become viral DNA. Amazing. Okay, so now let's go into the nucleus, where you have integrase inhibitors. Not many of those, but it's a drug that will stop integrase, which is an enzyme, from allowing the viral DNA into the DNA of the host. And lastly, we have protease inhibitors. Okay, and there's quite a list of them there. We'll come to a prototype later on. And what are they doing? They're interfering with the protease and inhibiting it, making it very difficult to produce new viral particles and sending new viral particles into the bloodstream to infect other CD4 cells. Okay, so now that we've gone through the two earlier slides, hopefully this slide just makes a bit more sense. So we've spoken about entry inhibitors. I dare you to try and pronounce them. That's why we use the brand name for some drugs. But enfuviratide is an entry inhibitor, and maraviroc is a CCR5 antagonist. But they both essentially do the same thing. They stop it from getting into the host cell. Then you have the next group, the 2A and the 2B. So the nucleoside and nucleotide reverse transcriptase inhibitors. So this is the group that tricks the reverse transcriptase into using them as analogs of the bases that are typically used in the production of DNA. And of course, the DNA is now ineffective. Okay? 2B is these are just drugs, the non-nucleoside reverse transcriptase inhibitors. They go right after the reverse transcriptase enzyme. It alters the shape of it and it makes it unable to add nucleotides and continue to build the DNA, the viral DNA. Number 3, integrase inhibitors, enzyme required to insert the viral DNA into the host DNA. There's a medication to inhibit this enzyme. And lastly, protease inhibitors, as we've spoken about, to prevent the final step by binding to HIV proteases and making them ineffective, non-virulent. Okay, so that's the whole. If you understand the process, a couple of prototype drugs will fit in nicely. Okay, so what about HIV testing? And typically, we need to counsel patients on HIV testing even prior to taking the test, because it's important for patients to understand that we can get false positive tests on the first way of testing. So the first way of testing is what's called an ELISA test. And an ELISA test is accurate, but we can also get false positives added into the test. So that can really create a lot of anxiety. So if patients know that they can still be negative despite a positive initial ELISA test, Okay, so if we look at this slide, if the ELISA test is negative, which is heading up towards the top of the slide, a negative test result, then really it's prevention of HIV um, through the use of avoiding high-risk behavior, using condoms as protection, and actually we can talk about on another slide that there's now a medication, an antiretroviral that can be used for patients that continue to have a very high risk lifestyle of acquiring AIDS. There's a medication that can be used to try and prevent them from from developing HIV in the first place, from getting infected with it. Okay, so we'll talk about that. So anyways, even though they're negative, they still need counseling in terms of what can you change in your life to prevent acquiring HIV. Because really, remember, it's a non-curable disease. We have treatments that definitely prolong the patient's life, and we actually still don't know how long the drugs will be effective for, because it's been over 25 years, it's 20 to 25 years now of having used these medications, and we're still having long-term control of this disease. So HIV is really a chronic viral illness now. Okay, what if the test is positive? So a patient comes in, we do an HIV ELISA test, and the blood test comes back positive. So now the patient will return, they'll be advised of the positive test, but also, hopefully, they were also advised that there is the potential for false positives. So we do a confirmatory test, and the confirmatory test for HIV is called a Western blot test, and that is a highly sensitive test. So if the Western blot test is positive, that indicates that the patient very, very likely now has HIV. If the Western blot is negative, then that means that the patient is HIV negative, and that you would continue to provide them with HIV counseling in terms of preventing the disease, reducing their overall risk, advising to reduce IV drugs, high-risk sexual behavior, and also the use of condoms. Okay, so this slide will hopefully make some sense now. HIV testing. So first off, high-risk behavior for HIV. So who are we going to think of that has potentially an HIV infection? So having sexual activity, so a patient having sexual activity with an HIV positive person, that's going to be high risk. Intravenous drug use, IV needle sharing, prostitution, and also patients coming in who have other sexually transmitted diseases. So patients with gonorrhea or chlamydia or syphilis, any other STDs make you at higher risk for having HIV. Why would that be the case? Well, if you're developing other STDs such as syphilis or gonorrhea, it's likely that you're also engaging in high-risk behavior, which puts you at risk for HIV infections. So we kind of will suspect HIV much more in someone who's having recurrent sexually transmitted diseases because of the behavior they're engaging in. Okay, so the testing we've already discussed. The only one we didn't mention is there's a rapid oral swab for HIV testing. The other one, the other one we mentioned, the first one is the screening blood test called the ELISA test. And again, that one can have some false positives, and we counsel patients on that. And then there's the Western blot blood test, which is a highly sensitive test. So it's the confirmatory test once somebody screens positive with the ELISA test. Okay, so what else do what other blood tests do we use? Well, somebody with HIV infection, we can follow their disease state and their immune status by seeing the serum viral loads, um, either before treatment, which typically they're extremely high, in the thousands and thousands and thousands, and the CD4 count is usually suppressed because so many of them are being destroyed by the viral infection. But we can follow the success of the medical treatment of the medications with viral load counts and CD4 counts. And the viral load is just measuring the HIV RNA in the serum or the plasma. And the CD4, which is the T helper cells, is just the serum level of those particular cells and what level they're at. And as the CD4 count drops below 500, we can predictably expect certain opportunistic infections occurring. So we'll see that on another slide. But as the counts drop below 500, you're so immunosuppressed that there are certain opportunistic infections that start to infect the body. So that is the definition of AIDS, when you get an opportunistic infection or your CD4 counts drop below 200. Okay? So best case scenario is that you have an undetectable viral load because of the medications you're taking, and that your CD4 count is above 500. So that's best case scenario, which is attainable now with the combination 3 or 4 antiretroviral drugs taken consistently every day for the rest of your life. So this next slide on HIV teaching. So the first bullet point is MD selection. That should really be HIV clinic. There are specific clinics that are used just for HIV positive patients and patients with AIDS. Since this is you can see that the medications have a wide variety, and there's all kinds of combination drugs that are used long term, of course, since we know that HIV is a chronic long-term illness now. Years ago, we didn't call it a chronic long-term illness. It was relatively rapid over the span of years, from HIV positive to complete destruction of your CD4 count to overwhelming opportunistic infections throughout the body. And that would include also developing certain cancers that were very rare in the general population. But because the immune system was devastated by this virus, patients would also acquire certain cancers, and I'll mention one a bit later. So really a dedicated HIV clinic. The concept of that HIV is a virus that constantly mutates while it's replicating. And that is one of the reasons why it's so difficult to treat, because it has constant ability to mutate to a slightly different form. And this leads to the next topic of adherence. It's critical that patients with HIV or AIDS, which is the disease that the HIV virus causes, they adhere to their medication plan very strictly. Missed doses is putting the patient at risk, or they are putting themselves at risk of acquiring resistant HIV. Since when you miss doses, the virus can now start to replicate again, and it can replicate mutated forms of itself that are now resistant to the medications that you were using. So adherence is critical, and lack of adherence would lead to resistant HIV. Infection rules. So this is just referring to sexual lifestyle adjustments. So patients with HIV need to declare to their partner or to report to their partner that they are now HIV positive, or if they're in multiple relationships, that they are HIV positive, or if they are sharing needles for IV drugs with other people, they need to report that they're HIV positive. What about pregnancy? So a pregnant woman is definitely taking the same medications or antiretroviral therapy to suppress the viral replication and to try and keep viral loads in the bloodstream to undetectable levels. And that's not only for the health of the woman, but it's also to reduce transmission through the placenta of HIV to the developing fetus. So taking HIV medications at any point in the disease process, whether you've just become HIV positive or it's been discovered suddenly through a blood test that you're now HIV positive, you will start antiretroviral therapy. Infants born to infected mothers typically take a drug called zidovudine, which is an antiretroviral drug, usually for 4 to 6 weeks, until they have repeat blood work showing that they are HIV negative. If they are HIV positive, then they would continue taking antiretroviral therapy to prevent their immune system from being destroyed and developing all kinds of infectious and cancerous consequences from a devastated immune system. So this next slide is a prototype slide. Enfuvirtide, or Fusion, which is even easier. And this isn't typically used very often. It can be used in HIV positive patients that have become unresponsive to other antiretroviral medications. And how does it work? Well, it tries to reduce the spread of HIV by blocking entry into the CD4 T cells, which is really what HIV attacks. This is only given subcutaneously, Um, and it can cause a bit of injection site inflammation. I'm not going to spend too much time talking about the individual drugs, except there's one coming up that I will spend a bit of time on. So I think just knowing that it's an entry inhibitor and how it affects HIV from entering the host cell. I don't think memorizing every drug is the objective of this module. Okay, so let's talk about zidovudine a bit, which we really used to refer to it as AZT. And it's one of the first antiretroviral therapies that came out years ago, well, decades ago now. And what we're really talking about are, so zidovudine is one of those one of the medications that are in the nucleoside or nucleotide analogs. So they trick the reverse transcriptase into thinking that they are actually base pairs or bases of the DNA. The reverse transcriptase incorporates these drugs into the production of viral DNA, which of course makes the viral DNA ineffective since it didn't copy the viral RNA properly due to these drugs, and it makes the viral DNA ineffective. Okay, so that's really how this group works. The nucleotide or nucleoside reverse transcriptase inhibitors. So what's the main side effect of zidovudine? Well, all of these three apply. So bone marrow suppression, which can lead to anemia, thrombocytopenia, and leukopenia, low white blood cells. Lactic acidosis is a condition that while taking this drug, you become acidotic in the bloodstream. So it's a side effect that's pretty significant because lowering of pH, which is acidosis, makes the really alters homeostasis and makes patients extremely ill. So remember, your pH in your bloodstream is usually 7.35 to 7.45. Lactic acidosis will drop it below 7.35, leading to a very sick patient. So this needs to be monitored. And the other significant side effect is myopathy, which is muscle breakdown. And we typically use an enzyme that we can detect in the bloodstream called CK, creatine kinase. And it's released from muscle. So we can see if there's muscle breakdown by checking for this particular enzyme. So under responsibilities, here they do mention a couple of the medications above that are used. They can all be used. So what do we want to check with zidovudine? Well, definitely any bone marrow issues such as bruising, weakness, which would indicate anemia, or advise again about developing fevers, which can be an indication of leukopenia and some form of infection. Checking the serum pH and lactic acid levels. The last part mentions a couple of drugs, erythropoietin and filgrastim. Those are basically hormones that we use to stimulate the bone marrow to either produce more red blood cells, in the case of erythropoietin, which is also made in your kidney, by the way, and filgrastim stimulates the bone marrow to produce white blood cells. And we'll talk about those in a different module. Zidovudine is usually taken with meals to try and reduce GI upset of this medication. So the next slide is a prototype drug for NNRTI. So a non-nucleotide reverse transcriptase inhibitor. And really what this does is directly inhibit the reverse transcriptase enzyme and stops it from producing the viral DNA. So efavirenz is the prototype here. I think if you just know the action and understand how it works a bit, realizing that with any antiretroviral drug, whenever patients are returning to clinic, they're going to get their CD4 levels checked. They're going to have their serum viral loads checked. This one, it's suggested to take with fatty meals to help increase absorption of it. And I think that's all I'm going to say about this medication. Okay, so under protease inhibitors, we have lopinavir/ritonavir. And lopinavir is the active medication in this pill. And ritonavir really just blocks the breakdown of lopinavir in the liver. And you're going to see this with other medications going forward in pharmacology, that sometimes another drug is added, not because it's active, but because it can be used to stop the breakdown of the active drug. Okay? So protease inhibitor, so it stops viral mRNA from synthesizing proteins, which are critical for new viral particles that can then be released into the bloodstream. So if we stop new viral particles from being produced, we will significantly drop the serum viral load, which would preferably be at undetectable levels in the bloodstream. Okay, so adverse effects. We've just known over having used these drugs for years that they can lead to diabetes, osteoporosis, which is thinning of the bones in the body. So reduced bone density is what happens in osteoporosis. And they can also lead to high lipid levels, so high cholesterol and high triglycerides in the bloodstream. So in terms of nursing responsibilities, monitoring blood sugars when they're returning to clinic while on these medications, they'll likely need bone density testing for checking if they're becoming osteoporotic. Monitoring the fat in their diet is important, since this medication can lead to high lipid levels in the bloodstream. And always, of course, reminding them to never skip a dose of medication, since it can lead to HIV resistant strains. So this next slide is on opportunistic infections. So what are opportunistic infections? Well, they're infections that are taking the opportunity of entering a patient because their immune system is impaired. So it could be impaired by HIV, for example. It could be impaired by someone taking steroids for many conditions. Chemotherapy for cancers impairs the immune system. Bone marrow failure from bone marrow cancers, such as leukemia, such as a condition called myelodysplasia, which is basically bone marrow failure and abnormal cell production in the bone marrow. So all of these conditions can lead to a weak immune system and put the patient at risk for opportunistic infections that wouldn't usually occur in someone with a healthy, normal immune system. So let's just look at a couple of these. So candidiasis. So oral thrush is another term for that. And actually, at the beginning, when we discovered HIV, or prior to that, we realized that many young males were presenting to hospitals with recurrent oral thrush. And that was one of the tip-offs that led us to an immunosuppressed state in these patients, and finally to the diagnosis of a virus called HIV. Other ones that would be extremely rare in a healthy immune system, such as Cryptococcus or histoplasmosis, those are deep systemic fungal infections, and they're taking advantage of the suppressed immune system and trying to set up colonies of fungus throughout the body because of the suppressed immune system. Pneumocystis pneumonia was again another one where young males were presenting to hospitals across North America with severe pneumonias from a very strange infection, which would not normally occur with a healthy immune system. And again, another tip-off that something is happening in a patient's immune system, and finally led to a diagnosis of HIV. So this slide isn't meant to memorize, it's just giving you examples of opportunistic infections. There's also opportunistic cancers. So patients with HIV, with immunosuppression, are at risk for very rare cancers. And an example of one is one called Kaposi's sarcoma, which is a cancer of the soft tissue and skin, and it looks like purple patches on the skin. And young males were initially presenting with Kaposi's sarcoma, which again was extremely uncommon if you had a normal immune system. Okay, so what about the goals of antiretroviral therapy? And we've spoken about this on different slides. So the first one is long-term suppression of viral loads in the blood. So when patients are routinely returning to HIV clinics, the aim is to have undetectable viral loads in the bloodstream. That doesn't mean that they are cured of the HIV virus. It just means that the viral load is so low that it's undetectable, since the drugs are inhibiting viral replication at multiple sites. There's such little amount of viral RNA in the bloodstream that it's undetectable. Restoration of the immune system, so improvement of T helper cells, the CD4 cells, into a normal range, which would be above 500, so that they don't acquire opportunistic infections and they're not at risk for having an assortment of different infections that in themselves require more treatment on top of the antiretroviral therapy that the patient is taking. Prevention of HIV transmission, we've spoken about that these drugs reduce viral load so low to actually undetectable levels in the bloodstream that we now know that this reduces the transmission of HIV um, to sexual partners, through sharing of needles, and say for healthcare workers, if they have a needle stick injury uh, with a patient who's HIV positive but has undetectable levels, it reduces the transmission. It doesn't reduce the transmission to zero, but it reduces the risk of passing on HIV. Prevention of drug resistance is definitely a goal, and that takes patient cooperation to adhere to the drug regimen and not miss doses. Improvement in quality of life, so patients with HIV can have a very good quality of life, especially when their immune system has recovered. They're not having to take an assortment of different medications to treat the opportunistic infections, and they're at much lower risk of developing cancers that may have occurred if their immune system was chronically weakened. So definite improvement in quality of life, since they're not constantly fighting not only the HIV virus, but also all the other infections that they acquire. So let's talk about post-exposure prophylaxis. So someone has been exposed to, or potentially exposed to, blood or body fluid that may have HIV, and we have the option of providing or treating them with post-exposure prophylaxis. So typically, superficial wounds are at very, very low risk of transmitting HIV to a healthcare worker. So even if we know that the patient is HIV positive, a superficial exposure, such as a needle stick that wasn't very deep, has a very low transmission rate. It's typically significant deep wounds that can transmit HIV to the healthcare worker, but even then, it's still very reassuring to know that the transmission rate is still low. Not zero, but very low. So post-exposure prophylaxis can be offered to healthcare workers who have had needle stick injuries, whether we know if the patient was HIV positive or not. We can still treat with post-exposure prophylaxis to even lower the rate of transmission further. And ideally, this is done in the first few hours after the needle stick injury or some kind of blood exposure from a patient. So after there is an exposure, and the highest risk is blood-to-blood transmission. It's almost unheard of to acquire HIV from someone's saliva. So it's typically blood transmission. So we would take HIV testing, hepatitis B virus, and hepatitis C virus testing from the bloodstream of the patient and the healthcare worker. Now, of course, if we know that the patient's already HIV positive, no need to repeat it. We already know that they're HIV positive. And then we would discuss the option with the healthcare worker in terms of taking post-exposure prophylaxis to reduce the transmission rate to even smaller levels. And this is usually for approximately a month that the post-exposure prophylaxis is used. And you can see some combination medications there. Those are the ones that are commonly used. They could switch in the future. They've been different in the past, just knowing that there's post-exposure prophylaxis. HIV testing would then be repeated at around 4 to 6 weeks, 3 months, and 6 months after exposure to confirm that the healthcare worker remains HIV negative, or unfortunately, they've tested positive for HIV. In general, this is a rare occurrence. It has happened for sure, but it's relatively rare unless it's a very, very deep wound with substantial transmission of blood from patient to healthcare worker. Okay, so what is PrEP? So pre-exposure prophylaxis. So there's now a combination pill called Truvada. That's the brand name, which is a combination pill of 2 antiretroviral medications in one pill. So who would benefit from taking Truvada? Well, if you are HIV negative and you have an HIV positive partner, then you have a chance of acquiring HIV through sexual activity with your partner. Truvada can significantly reduce the transmission to the HIV negative partner. So it works, you take this medication daily, and it essentially stops the HIV virus from even starting an infection in the CD4 cells. So it really reduces the chance of acquiring HIV, despite the fact that you are not completely avoiding high-risk behaviors in your life. So sexual activity with an HIV positive partner, not consistently using condoms would be high risk as well. A sex trade worker who is currently HIV negative would be considered high risk, or a patient who has multiple partners but is still HIV negative. And of course, if you're continuing to take intravenous drugs. So maybe some of you are thinking, well, why are we providing a medication to someone who's not altering their lifestyle and trying to reduce their risk of acquiring HIV? Well, it takes time to alter behaviors. And we know that HIV is a chronic viral illness and there's no cure for it. So by using a medication, in this case Truvada, which is the only one available for this indication, you can reduce the chance of the patient acquiring HIV while also trying to counsel them on reducing high-risk behavior, which may take years to alter. But in that time, it may help prevent them from acquiring HIV. And it's significant. It's an effective treatment from stopping HIV from taking hold in a patient and now having the disease, the viral illness chronically. So very effective treatment to prevent HIV in high risk populations.